This is bread and butter radiology, CT pulmonary angiogram performed to rule out embolism. The way the CT is performed is to give contrast and make sure that the concentration of contrast is maximum in the pulmonary artery. So the normal enhancing pulmonary artery is bright, as you see here. Anything that's dark within the pulmonary artery represents a filling defect. In this case, the pulmonary trunk is normal. Part of the right and left main pulmonary arteries are normal. However, there are large central filling defects, as you see here, on both sides, representing pulmonary emboli. Note how the central pulmonary emboli extend into the lobar and segmental pulmonary arteries. And here's a nice example of extension into a pulmonary arterial branch. So this is surrounding contrast, and this is the acute central pulmonary embolism. One classical appearance of acute pulmonary emboli is that they get stuck at the bifurcation and then they divide into smaller branches. So the most important finding here is the presence of large bilateral pulmonary emboli. However, there are other features I would like to emphasize on this scan. But before I continue, please look at this structure here. My question is, what do you think this structure represents? This is a bonus question. I'm not going to answer in this clip. I'll give you the chance to respond. So again, what is this bright structure here? You could answer by responding on Snapchat, Twitter, YouTube, or others. Now that we got that question out of the way, let's continue for the other findings that I wanted to emphasize on this scan. In a normal CT scan, this here, the intraventricular septum, should curve towards the right side. It doesn't matter whether you catch the scan at ventricular systole or diastole. Since the pressure on the left is always high, the curvature should always present to the right side. In this case, there's straightening of the intraventricular septum, and even you might see some bowing to the left side, to the opposite side. So this is abnormal. And straightening or bowing to the left side of the intraventricular septum is a sign of increased pressure on the right side. Another thing that's abnormal here is that the left ventricle should never be smaller than the right. Typically on subjective assessment, both ventricles have more or less the same size. However, if you look at the enhancing right ventricle here, it's obviously larger than the left. The same applies to the atria, and this is your left atrium, this is your right atrium. And it's so obvious that there is right atrial dilatation, very clear compared to the smaller left side. So if the pressure or volume increases on the right, there could be reflux of blood through the tricuspid valve leading to dilatation of the right atrium. Again, tricuspid regurgitation may be the cause for dilatation of the right atrium here, and it fits with what we're seeing with dilatation of the right ventricle. Now, the way we inject contrast is from an upper limb. We inject it through the left side, and that's why you see this dense vein here. It goes through the venous system in the upper limb to the left brachiocephalic, reaches the SVC, and goes all the way to the right-sided cardiac chambers. Now, what's a bit peculiar is that there is reflux of contrast into this structure here, which is the inferior vena cava. Not only that, there is reflux of contrast into these veins in the liver, which are the hepatic veins, meaning that the blood and contrast here are running in a reverse direction, a retrograde direction. Instead of going to the heart, it's going away from it. And again, such a finding is a sign of high pressure on the right side, leading to reflux into these structures. All these signs denote right-sided heart strain. If you're reporting such case, these signs are very important. That elevates the seriousness of the case to another level. Since the combo of acute pulmonary embolism, especially of this large size, with right heart strain denotes poorer prognosis. What we commonly see in radiology practice is that radiologists would report the pulmonary embolism, but would not comment on all these signs of right heart strain. So let's summarize what we talked about today. First, pulmonary embolism could be seen on the CT pulmonary angiogram that is performed with a specific technique. The most important thing that we talked about today are signs of right heart strain on a simple CT pulmonary angiogram. First is straightening or left-sided bowing of the intraventricular septum. Second is dilatation of the right ventricle or right atrium compared to the left side. Finally, reflux of contrast into the IVC and into the hepatic veins. Just a note of a pitfall for radiology residents: you may have reflux of contrast without the other features in normal patients. This may happen in a normal patient without right heart strain because we use a power injector to give contrast, and this power of injection might lead to that. So keep that in mind when reading these cases, and make sure if you see reflux of contrast to look for the other features that we just talked about. Before I finish the case, a reminder: what do you think this structure is? Answer on any of our social media platforms. Thanks for watching. More cases later this week. This is a cardiac CT on a 57-year-old male patient. The patient had normal coronary arteries, but there was this additional finding here. For the sake of orientation, this is the left atrium, this is the left ventricle, this is the right ventricle, and this is the right atrium. This is the intraventricular septum between the left and the right, and this is the interatrial septum between the left and the right. The interatrial septum is usually a straight line. However, there is a bulge here that is well defined. The bulge is directed from left to right. It involves the mid-septal portion, more accurately known as the fossa ovalis, and it has the density of the left atrial contrast filled cavity. This is a relatively common finding on cardiac imaging, and it's due to a floppy mid-septal portion. This floppy portion, according to the pressures in the atria, could protrude from left to right or right to left, and is known as an atrial septal aneurysm. Now, the reason you need to know this is not to confuse it for a shunt, such an ASD. And if the bulge is directed from the right into the left atrium, it could look like a filling defect, so don't confuse it for a thrombus or a mass. Despite saying that, there may be some clinical significance when you see this finding, since this finding may be associated with an atrial septal defect, ASD, or a patent foramen valve, PFO. And in this particular case, you notice that there is an area where you have contrast directed from the left into the right side. This jet of contrast appears turbulent and ill-defined when compared to the rest of the atrial septal aneurysm. And although this is a static image, you could tell that this is a shunt, likely a patent foramen valve directed from left to right. Now, I know some of the residents would say that this is a cardiac finding. We're not going to be cardiac imagers, so who cares? Well, such a finding is important since it could be easily seen on your regular chest CT. And this is the chest CT on the same patient. And here's your atrial septal aneurysm and the turbulent flow of contrast from left to right due to the patent foramen valve. Both findings which may be very confusing if you don't know both entities. To summarize, today's case is basically a show and tell case. We learned about an entity called atrial septal aneurysm. We also learned that it's a common incidental finding which may be associated with atrial septal defect or patent foramen valve. Thanks for watching. More cases later this week. This is a CT head without contrast on a 21-year-old male patient. The abnormality is obvious. There is this large and heterogeneous mass that is mainly left-sided but extends across the midline and leads to this midline shift. The lesion has this cystic component that has a low-density fluid which is different than CSF. and has this heterogeneous and somewhat bubbly appearing soft tissue component which shows high and low density. There is associated hydrocephalus, which is sparing the ventricular system in the posterior fossa, such as the fourth ventricle. So a large cystic and solid heterogeneous lesion that leads to obstructive hydrocephalus. Despite the large size of the abnormality, there is no clear surrounding edema. In addition to the mass effect exerted by the lesion, such as the midline shift and the check for transtentorial herniation, you have to decide whether this lesion is arising from CSF spaces, extraaxial, or from the brain parenchyma, which we call intraaxial. We discussed the difference between intra versus extraaxial lesions before. Let's emphasize this here. Given the large size of the abnormality and the absence of edema is something that favors an extraaxial lesion, but it does not confirm it. Given the displacement of the brain parenchyma outwards and the displacement of the septum pellucidum to this side, there is a suggestion that this lesion arises from here. And this area here is where the foramen of Monro or the body of the lateral ventricle would usually be located. If the lesion is compressing on the foramen of Monro or the third ventricle, it wouldn't be surprising to see supratentorial hydrocephalus. Now for more assessment, let's look at the MRI images, starting by the sagittal T1 weighted image. And here you see the heterogeneous lesion with a large cystic component and a bubbly appearing solid component. Abnormality displaces the corpus callosum superiorly and compresses on the roof of the third ventricle, which is flattened here. This here is a coronal T2 image on the same patient. The intraventricular location of this abnormality is more clear looking at multiple planes. And on T2, fluid would appear bright, and that's why the cystic components appear bright on T2 compared to the dark that we saw on T1. Here's an axial T2 showing the bright cystic components and the darker solid components. How the dilated CSF-filled ventricle has fluid that's slightly different in color to that of the cystic component of the lesion. This is a T1 image after giving intravenous contrast. Although the cystic components do not enhance, the solid component shows variable degrees of enhancement. Here you have strongly enhancing areas, while here you have intermediate enhancement. To summarize our findings, we have a large heterogeneous intraventricular lesion, likely arising from or at least affecting the foramen of Monro and leading to hydrocephalus. The lesion has cystic and solid components which show variable degrees of enhancement, leading to focal midline shift and no associated vasogenic edema in a patient who is 21-year-old. All these features point to one specific diagnosis. This is a classic appearance of something called a central neurocytoma. This lesion classically occurs in patients who are young, between 20 and 40 years old. It's not a very common lesion, but when it does occur, it typically affects the intraventricular compartment. It classically arises from the area of the foramen of Monro or the ventricular components surrounding it. The classic treatment for this lesion is resection, and if the whole abnormality is resected, it's usually curative. In cases where partial resection is performed, chemotherapy, radiotherapy, or both may be implemented. One of the classic descriptors for a central neurocytoma is a bubbly appearance, something that's similar to what we see here. It classically has cystic components, solid components, which may calcify. The solid components may show strong or intermediate enhancement. Although this is a show and tell case for seniors, there are lots of points to take away even for juniors. Most importantly, when you see a mass lesion, decide what effect is this leading to in the form of midline shift and herniation. Then decide if you think this is an intraaxial or an extraaxial lesion. MRI is a very good tool in further tissue characterization of this abnormality. And finally, a classic cystic and solid bubbly appearance that arises in the ventricle of a young patient is a central neurocytoma. Remember that there is a differential diagnosis for intraventricular lesions. However, most of the differential diagnostic possibilities do not fit here. An older Radiology Bits YouTube clip actually discusses the differential diagnosis of intraventricular masses, so you could go back to that. That's it for today's case. Thanks for watching, and see you with more cases next week.